The webinar. Today I'll be covering two main topics. One is elastography, and other one is a technique that you can use to image superficial structures. So let's start with elastography. If you were at the symposium and if you attended my intermediate ultrasound presentation, this was covered there. So this is like right from that portion of the presentation. So let's start with elastography. I'm not sure if you are aware of this technique, which is new, relatively new. They're using it in other areas also other than MSK, like breast imaging and thyroid and liver imaging. And so elastography is essentially study of mechanical properties of the tissue. And so what we do is we check the tissue stiffness and elasticity of different tissues. There's a force that is applied which deforms the structures, and how much a structure or a tissue resists to that deformation is what is measured on an index. So there are mainly two types of elastography that is in use at present, and that is strain elastography, which you can see on the left, or shear elastography, which you see on the right. So let's talk about strain elastography. So what is done in a strain elastography? There's a compression which is applied, as you can see this downward arrow. So with transducer, you deform the tissue, and when you let go, and there are cycles of it, of course, how much you deform the tissue and how much the tissue resists that change is what is calculated by the machine. And the machine gives you a spectrum of red to blue. Red means softer and blue means stiffer, and that's how you see regions or tissues, or within the tissue different regions where the tissue has different elasticities than other. So the most important application at present in musculoskeletal imaging is in tendon imaging. So with elastography, if you combine our B mode imaging, which we do, we all do B mode imaging, which is brightness mode imaging, with tendinosis or tendinopathy or other tendon diseases, what we see is hypoechoic tendon, which is enlarged. Now, if you combine elastography with that, you can also see the regions where there are changes, or which are losing its elasticity, or there are changes in the mechanical properties of the tissue. And sometimes you can see that even in early stages. So even before you see much of the changes, you can pick up with elastography. Now, second one is shear wave elastography. So here there is a shear wave which is transmitted from the machine or the probe itself, and the shear wave moves through the tissue, and again how much of deformation that shear wave causes is what is recorded by the ultrasound. So again, you see a spectrum of red to blue, and of course I have images coming next in the next few slides. You will see the regions where you see less stiffness, or softer regions will appear red, and the harder will be blue. So let's look at one more time. So there are two types of elastography. One is strain, the other one is shear wave. In shear wave, in strain or compression elastography, we put pressure. Same like sonopalpation, when you put pressure through the probe. So you're deforming the tissue, and then the tissue is graded on the index of elasticity. In shear wave, the ultrasound machine sends the stimuli, and there's a debate at present. Some people prefer the shear over strain because there is a learning curve that you have to have a certain amount of pressure, and although machine has this calibration how much pressure you should be exerting, there's a little bit of learning curve of how much pressure do you have to exert to measure that, and so there's a little bit of learning curve of performing strain elastography, which is also operator dependent. Now, so look at these images. So this is how elastography appears. So on the left, you can see this is a tendon, and when you turn the elastography mode, you can see that's the tendon, that's the soft tissue or the fat pad, and you can see that that area appears softer, and then the muscle part again appears harder, right? So that's the normal tendon, and this is Achilles tendon. So you can see the tendon, you can see the softer area, and then so the tendon, this is how a normal tendon appears on elastography, as you see on the left. Now there's a study done, and they report that they measure they did elastography study on two groups of subjects. One is with healthy volunteers and people with Achilles tendinosis, and they were, both the groups were of similar age and BMIs. And with tendinosis, they found these changes, which you can notice on the elastography, and these changes are associated with the early tendon degeneration. Oh, I'm sorry. Let me say it again. These patients, these subjects were not patients with symptomatic Achilles. I'm sorry. So these were athletes, and they imaged Achilles tendon of the athletes and healthy volunteers, which are not athletes, regular people, normal people of similar age and BMI. And in non-symptomatic athletes, they found some changes which are consistent with early tendinosis. So on the right, you can see there are grades A, B, C, D. So you can see the area of the red area is getting more and more is more significant in D versus C, B, and A. So these are just gradation of abnormality, and so these are people who were not symptomatic. So many years ago, when I was in my I was doing my master's thesis in University of Southern California, my thesis my research was also on tendons, and I utilized ultrasound for that. I had 4 types of patient population. One was a patient with the symptomatic tendinosis, so Achilles tendinosis or tendinopathy, then athlete, but not non-symptomatic. So same like this study that you can see on this slide here. So symptomatic tendinosis patients, and just athletes but non-symptomatic, healthy volunteers who never ran or no athletic activity, and the 4th one was paraplegics, so disuse atrophy. So these are the 4 groups that we studied, and we also found the similar changes, although we did not study elastography at that time. This is a much more recent technique which is used, but we collaborated with the engineering department of University of Nebraska, and you can analyze these ultrasound images and do a Fourier analysis and see how the collagen organization is changing. So there was a spectrum. So from healthy volunteer to non-symptomatic non-symptomatic subjects to symptomatic subjects, there was disorganization was getting more, and the tendon was getting more and more disorganized. So that's a trend that we saw in micromorphology of the tendon, and I think the same thing we can see here, even without doing that fancy Fourier analysis, which takes, it's a very complicated analysis which only those engineering people can do. I think now we all can do as a clinician. If you utilize elastography, I think we are looking at that disorganization and also elastic properties which are changing in the disease process. So this is a very promising area. So I have a different machine now, and I have this elastography mode, and I'm experimenting with that. So you'll see more images coming from me in the future and more presentation. So next slide is a patient with patellar tendinosis. You can see focal thickening here, hypoechoic areas, and then as we go distal, the tendon fibers are normal looking, right? And now when I turn the elastography on the right, you can see these changes, right? Look at the areas. There are red areas, which means like that area, those areas are the softer areas, loss of elasticity, loss of stiffness of the tendon. So That's a normal B mode. So you, of course, you know with elastography that there are some changes, and also you know with B mode that there is focal thickening and hyperechoic signal in the tendon. Now the normal tendon, look on this side on the left, is B mode imaging, and you can see the normal tendon here. And here with elastography, if you compare with the previous image, which is here, look at this tendon versus this tendon. So it does give you a very good idea of the stiffness or mechanical property of a tendon. So there's a great application if you are treating someone and you don't see any significant changes on ultrasound, maybe when you scan them, but maybe if you use elastography, you may see these red areas changing to yellow or green or blue, which is again an indicator that their tendon is getting better. Now another study was done on smokers, and they measured their strain ratio. So basically they did elastography on smokers, and they did imaging and elastography on their Achilles and patellar tendon. And what they found is in smokers, they have thinner tendons. So on B mode imaging, they found that the tendon they were smaller than the healthy volunteers, and they were also harder. So on the other spectrum, when you have tendinosis or tendon disease, you have softer tendon or you have less elasticity. When someone smokes, then they have thinner tendons, and they are harder than the normal tendon. So on the top you can see smoker, so that's the B mode image of the patellar tendon, and you can see there are more blue areas, so that means it's harder compared to the healthy non-smoker, where you can see fibrillar arrangement, and it doesn't show as much blue area. And of course they did it on large group of patients, subjects, and that's how they established this one. Okay, so far on elastography, anyone has any questions? We can discuss this a little bit. Any questions, comment? All good? Okay, Vicky has a question. Yes, I think you're self-muted, Vicky. Can you unmute yourself and then speak? Can you not unmute yourself? I saw a raised hand, but okay. Oh, it says you're muted by me. No, I'm clicking on that and it's here. Oh, now
okay, I'm here now. Yeah. So I had a question about, in the smoker's tendon on the top one, the blue so blue shows that there's increased resistance or hardening of the tendon. Is that a normal finding? Okay, I was thinking that was a normal finding.
No.
And that the green was more softening from the previous slide.
Yes. Yeah, so it's a spectrum. So you have, like in ultrasound, everything is relative. So in elastography also it's relative. So if you sample, let's say 100 images of normal healthy tendons, you will not see as much blue areas. Or I don't think we have true definition of how much blue or green you should see. This is just a comparison. They just found it, and I don't think we have a standard that we can say, okay, it should be this much blue and this much green. But what they found is the smoker had relatively more blue area than the normal, which means that it was harder than harder than the healthy tendon.
Thank you.
Yeah. Okay. All right. So I guess no more questions from this part. Okay. So let's move to the next one. And I have an image, so you can unmute yourself, everyone. I think I have unmuted everyone. Okay, so now a quiz question. So that's an image on the left, and you can see that. Now, any guesses what that is?
Looks like a quarter.
You're right. That is a quarter. Okay, so now the next one, a quarter again, right?
Yes.
So okay, now how about this one? Any guesses, anyone else? Ben, Kay, Roy? Any guesses?
It looks like a belt buckle.
It's possible. No, it is a ring.
A ring.
You know, a fun fact, if you check, real diamonds are anechoic, like an artery. So if you want to do a side business and, you know, but just deal in diamond, like be a diamond merchant, you can check if someone has a real diamond ring or not. So if you do ultrasound, it just like, it goes fast through this next interface, so you just see empty space. You just see the setting of the metal, whatever the metal is, white gold, red, yellow gold, and the diamond is actually anechoic. And the diamond is also radiolucent, so even on x-rays you just see like empty ring and no diamond there. So that's a fun fact. I thought I'd just, you know, throw it there. Okay, so now how am I doing these images? These are the ring image here and the quarter image in the and you can see it. Can you see the eagle here?
Yes.
Yeah, and
that's on the first one you could see it said quarter at the top.
Oh yeah, I know.
Liberty. Yeah, Liberty. Yeah.
You can also see a little bit of like,
yeah,
you know, John Washington here. I just found this so cool. I was so excited to put it here. So that's all water. So you can use water bath, or, you know, if you have a big bucket or a like a big Tupperware, and you just fill it with water and have the patient put their hand there. Superficial structures can be oh, sorry, Roy is trying to talk, but he cannot. I unmuted. Okay, how about now? Try it. Try it, Roy. Can you speak now?
I think I can speak now.
Okay, all right. Okay, yeah, so yeah, so we I don't know what I was saying. Yeah, so you can put extremity. So I would say, like, for the foot imaging and hand, you can use the water bath. Now for images like this quarter, I would have to use a lot of gel to get all the edges. You can see the serrations, right? You can see very nice detail here. You can I think if I have to take multiple images, because you can also see a little bit of liberty written here, and the this eagle here. You can see the eagle here. So it gives very good resolution for these fine details. Now, like this one, so this is what you can do for very superficial structure. Like, let's say someone has a nodule between PIP and DIP, and you're trying to image, but you cannot find it. And it also gives it also puts your focal point at the correct level, which is sometimes hard with the very superficial structures. So, you know, your focal point should be at the level where you want the maximum resolution. But when your structure is too superficial, it cannot move that far closer to the top part of the screen or the superficial structure. So that adding a layer of gel or water or standoff pad brings the focal point to the correct level. So now look at the image here. Of course I put two images together so that I can show you the whole digit. This is dorsal aspect. And I think all the people that are here, they have all done module 2A and are familiar with upper extremity imaging. Now that's dorsal aspect of the digit. So this is distal phalanx, this is middle phalanx, and that's proximal phalanx. And can you see the extensor tendon?
Yes.
Yeah. So this is much harder to see when we do with, no matter how much gel you put, sometimes it just gets so messy, and then when you're imaging, you don't see it very well, and sometimes you just have to rely on dynamic assessment. But water immersion is actually great, because you can see it much clearer here, because your focal point is exactly at this level, and the nail is not as hyperechoic. So if you remember when you did dorsal wrist digit imaging, nail looks almost like same like bone here, right? You have a hyperechoic bone here. Yeah, now because of the change in the interface between this before the skin, it's not as hyperechoic. So even if there is some abnormality in the nail bed, you can see it much better with water immersion technique. So look at this image here, right? So this is the distal tendon. It's very clear here, and I'll show you more images, and it's much clearer than just doing with the regular imaging that we do with gel over the finger. Now we are going a little bit more proximal. So this is again middle phalanx, and this is proximal phalanx, and this is, oh sorry, this is metacarpal, and this is MCP joint. And look at how thick it looks. It looks as if it's flexor tendon. So I'm using less depth also, so you can see the tendon, and you can see the tendon attaching to the proximal phalanx. This is also a difficult part, right, to get. You can see the fibers here. So if someone has extensor tendon tear, it's much easier to see if you have them, if you use a water immersion technique. Now let me. I have a video clip here where you can check the integrity, and you can see the tendon gliding so well. So this is DIP. I'm going to hold it for a second. So this is proximal phalanx, distal phalanx. This is the nail. That's the nail, and this is extensor tendon. Okay. Now just watch the tendon here. Now look at it. Look at the gliding.
Yeah.
Right, you can see it much clearer, and you can increase the range of motion, flexion, or you can see the movement translating proximally and how it's going up and down, right? So this is makes it much easier to scan, and you don't have to worry about spreading the gel all around, but make sure that only the part which is where you put the gel, that part is immersed. You don't have to, don't put it where the cable connects to the transducer, just up until where you would put the gel. So if you think of transducer as like, the junction of head and neck, like in femur, only up till the neck, not beyond that.
How far up off of the you're not actually making contact with the skin, right? So how far above it are you?
So I would say like maybe about I'm just above it. So if
above it, okay.
Maybe like half a centimeter or centimeter. But yeah, I'm not touching the finger.
Yeah, that's kind of the way we do underwater ultrasound anyway. You don't touch the part.
And you have a big pool, right? You can pretty much check everything.
Yeah, I have a giant pool, so yeah, I can look at everything.
You don't have any problem. Okay, yeah. So yeah, only so you don't want to, not beyond this point. So basically, the area where you would put the gel, that's where you want to. That's the level you want to keep it immersed. Okay, someone has a question here, I think. I saw a raised hand, maybe Kay. Okay.
Okay, can you hear me now?
Yes, I can.
Okay, great, because I have been muted. But Vicky's done a great job of asking all the questions I was going to ask, so thank you.
Okay, you can ask me a question if you like.
I can now that I'm not muted. That's good.
Do you have any questions so far? Or Vicky?
No, Vicky asked all my questions.
Okay,
she
good.
Covered them.
Good. Very good. So let's move forward. Okay, so now I have some cases. So this is a patient, and came with the numbness, tingling, so carpal tunnel type of presentation, and also diffuse pain in the hand and wrists, or like, wake pain, it just hurts everywhere, the wrist and digit. So now my question here is, like, so have you have a patient like that, and so I measured the median nerve, and it's big, it's 0.14 centimeters square, and I feel like, I have answered the question. Okay, it's carpal tunnel, and of course I did EMG and this one, and so should you just end your exam there, or should you put, spend a little bit more time and find out if there is anything other than median nerve involvement here? So the answer is you should, especially in patient where although you have partial answers and you have answered one question, okay, the median nerve is hypoechoic, it's swollen, so there is entrapment. You should look for a little bit more and spend a little bit more time. So look at the color Doppler image of this area here, because this patient had difficulty with like gripping activities and pain with the finger flexion extension and diffuse pain around the wrist and finger, and difficulty with anything to do with the hand. So with color Doppler, and when you use color Doppler, I know some people are using it, and there's a lot of motion artifacts. So in the beginning, especially when you are getting used to using this mode, you have to stop breathing actually for those few seconds when you're doing it, because if you move too much or the patient is talking, you get motion artifact. We don't want motion artifact. We want consistent color Doppler. So this wrist, if I turn the color Doppler, and you will see the areas that are lighting up, they will come like a pulse. You will see them lighting up, and so it's like on and off, but the same areas will show color Doppler. So when you see color flow, make sure you can repeat it at least one more time, the same pattern. That's how you know that this is true vascularity and not motion artifact. In long axis, and of course, try to get that in long axis. So here, look at this patient. Although, like, looking at just B mode imaging, you don't see any significant hypoechoic signal which you would like be concerned of, but look at the vascularity. So this is like early tenosynovitis, and most likely the carpal tunnel is secondary to this inflammatory tenosynovitis, and not primary. So this is our it's our responsibility to do a comprehensive assessment, so this patient does not get treated as a primary CTS. And some people would get surgery for this, or some type of intervention when that's not the primary. So no matter how much you treat the median nerve, you have to treat this too, right? Otherwise, even if you release it or inject it or something, this also has to be taken care of. Everything, pretty much everything else other than median nerve in the carpal tunnel. So that's the short axis and long axis view of carpal tunnel. And also look at the joint here. If you have done some wrist ultrasounds, you know how distal end of radius looks like, right? So sometimes these changes can be subtle, you can overlook them. It's good to know normal variations, because sometimes bones have they have normal contours where you can get a little bit of appearance of irregularity, which is none. But here, if you check it in long and short, this will look irregular, and this you cannot clear it up. And a very good indicator, put the color Doppler. If it lights up, it's definitely synovitis that you're picking up there. So I see some question marks here. If someone is asking, anyone? I think I'm unmuted everyone. Why do I see questions here? Okay, anyway, so yeah, so this is the joint of the same patient. So there is definitely some type of inflammatory arthritis, and also some type of inflammatory soft tissue disorder going on. So this patient needs to see endocrinologist or rheumatologist, someone like that, before just jumping on to any non-conservative carpal tunnel type of treatment. So how would you write this one? Give it a try. Impression. So there is definitely median nerve enlargement, and median nerve is hypoechoic and swollen. But in addition to that, other changes, how would you define it?
I say vascular changes in the flexor tendons, suggestive of thickening and fibrosis, and cortical changes in the radius, suggestive of arthritic changes.
Okay. Yeah, but and I wouldn't say thickening and fibrosis, because tendon, if you just look at this B mode image and you don't look at anything else, the tendons are looking okay. They're not looking that bad, right? So but the joint is definitely. So I would say there are cortical irregularities and evidence of early joint erosion. You can also say that erosion, early mild changes of erosion, and there is positive color Doppler sign which suggests vascularity, so it's suggestive of synovitis or synovial inflammation. In tendons, there is no significant hypoechoic signal. However, there is positive color signal on color Doppler, which is positive for vascularity in the tendons. So this is again suggestive of some type of inflammatory or early tenosynovitis of the tendons. So this is inflammation, because you see vascular changes all around. Some type of new angiogenesis is going on. So yeah, so you would say something like that. And then if they have, let's say, changes, pain or some complaints or pain in the digits, so you make sure that you cover those digits to not just end in the wrist, and you may see changes like that. Look at this metacarpal head. So that's the MCP joint area. Now there is a little bit of step off, because where the neck and head meets, but this one is definitely irregular. You can see that this looks like erosion, right? So then you are more suspicious of some type of rheumatoid arthritis or inflammatory arthritis. And you can always put like all the findings of what you found in carpal tunnel, what you found in the joint area, the digit and everything, and you can say all these findings are suggestive of a type of inflammatory arthritis. And of course clinical correlation is recommended, and you can recommend further imaging. And if you know who you're sending it to, you can also attach a letter, separate letter, that this is what you found and this is what it's suggestive of. Now the right image is again of the digit, but this one is not from the same patient. But again, like I'm showing you arthritic changes. Now here you definitely see osteophyte and the joint inflammation and effusion. So it starts like that. I would say this is more chronic. So it starts off like that and then it progresses to that. And here you may not see positive color Doppler here. Because there are changes, the synovial membrane thickens and then there's a fluid here, but there's no active process going on. So active inflammation, you normally see a lot of color flow.
So Mohini, can you just recap what exactly, kind of how you say that? I'm needing to hear it again.
Okay, so say it again. Okay, I'll say that there is focal enlargement of median nerve at the right wrist with the hypoechoic signal and focal enlargement of the right median nerve at the wrist, which is suggestive of entrapment. And also noted cortical irregularities and erosions at the dorsal aspect of the wrist joint or the volar aspect of the wrist joint, which is accompanied by hypoechoic signal around it, which is suggestive of synovitis. There is also evidence of vascularization, as evidenced with positive color flow on color Doppler ultrasound around the flexor tendons and the joint area. Together, this appearance is suggestive of inflammatory process and arthritis. Good?
Yeah, that was a lot. I still have to think about it again.
Okay, so we just go one by one. Which one do you want me to repeat? I can repeat that.
Just so skip the part about the median nerve because I kind of got that. But go back to the colored Doppler part.
Okay.
That's what I need.
So the joint, you know, right? Joint, you will say there are irregularity and there are erosions, areas of irregularity and erosions and loss of edge. And after that, you will say there is evidence of vascularity around the joint, whichever aspect you notice, dorsal aspect, molar aspect, or whatever, and around the flexor tendons of the carpal tunnel.
Okay.
As evidence with increased color, increased flow on color Doppler.
Okay.
Yeah. So that
seemed more concise to me. Yeah.
Yeah. Yeah. So yeah, all the findings like in different points, and then together you can make a suggestion that together they are suggestive of inflammatory arthritis or inflammatory process.
Okay, thank you.
Okay, all right. So now, okay, now another one. Now this is different patient, not the same patient. Now this patient, let me see if I have that image. No, I don't. Okay, this patient's median nerve was 0.12, not like too big. It's big. You can say it's carpal tunnel. Again, this is the patient I got from a rheumatologist. So I make sure that I see some subtle changes, but this was not so subtle. So let's say you have a busy day and you did an exam and you know that they have carpal tunnel syndrome and that you find their nerve to be 0.12, and then you get a long axis just because you want to get two views. And would you stop here? What do you see different in this image? So if you remember imaging median nerve in long axis, how does it appear? You see the tendons and then you see median nerve over that. But look at this median nerve. It goes like this up and then it goes. It's almost like it's as if it's curving around the tendons. And the tendons are also curving around something. And look at this something here.
Yes.
So yeah, the course is not, it's funny, you know, it's more or less parallel. You know, you don't see, you do see some, it's not exactly like a straight line. You do see some curving, but this is more dramatic. This is more dramatic, as if it's bending over a round object, right? So look at the distal end of radius, and this is the now this area is diffuse. So there's some deposit here. Now this patient was not, I don't know if they have it because the patient didn't know. It could be some type of deposit like gouty deposit or calcific deposit, but definitely a big synovial hypertrophy. So there's a mass which is most likely just a synovial hypertrophy with some type of deposit sitting here, and it's distorting the tendons and the contents of the carpal tunnel basically. So this is a secondary compression for sure, because this median nerve, although it's enlarged, but it's not that big. It's not significantly larger. But bigger problem is down under. It's not the median nerve. It's there is a some joint process, some type of arthropathy or some joint pathology which is causing, which is occupying the space in the carpal tunnel and pushing everything up superficially. So there's pressure secondary to that on the median nerve. So make sure you, like now, because you're used to looking at these images, it's good to know how normal. That's why we practice and we spend so much time understanding the normal, so that whenever something is different, that looks different, you should be able to investigate a little bit further. And sometimes these are subtle changes which can really help the patient tremendously. And so you wouldn't send, like, let's say if this is your first patient which is coming to you and you're the first contact, you would send them to the right provider or treat them in the right way, send them in the right direction. You wouldn't send them to hand surgeon. You would send them first to someone who would treat this or take care of this or educate the patient on this. So that's that. Okay, so here you can say that there is a hyperchoic diffuse hypoechoic signal on the volar aspect of the wrist joint with areas, hyperechoic areas within it, suggestive of synovial hypertrophy or a soft tissue mass with some type of deposit, could be gouty or calcific. Clinical correlation is recommended. It is also seen, there's also evidence of this mass compressing or compressing the structures of carpal tunnel in the right wrist. So you can make the suggestion that this mass has a mass effect on the carpal tunnel. Okay, very good. I think that's the last one, the last case. Now we are here. This is ankle. So posterior tibialis tendon. So this is a patient, and let's say if you find a posterior tibialis tendon which looks like this, what is your thought here? What are you seeing?
Reference.
So I'm on the medial side, but I don't have everything in the view because I wanted to enhance in focus on this one. But you know, there's FDL, there's nerve, there's artery, helices here. This is the first tendon, right? Posterior tibialis tendon. There's a focal anechoic defect there, right?
Yes.
Yeah, so you're seeing this focal anechoic. It just looks like there is something missing there, or so it could be a tear, or maybe some type of most likely a tear, or sometimes you can have like ganglions which can infiltrate different structures, which is although very rare, but you never know what you see in ultrasound. So in long axis, now if you just end it right here, we don't know what's going on in here.
Right.
In the long axis, do you see the split tear here of the posterior tibialis?
Yes.
Yeah, you can see that. That's nice and clear. But if you are long on it, and let's say you're not at this level, you are somewhere here or here, you would miss that.
Right.
Right here, you can see it's very clear. You can see the fibers down, but you can see fiber above, and then it's nice and clear split tear there of posterior tibialis tendon. So it's for every tendon, when you especially when you have something abnormal, you want to make sure that your long axis is over that area, or the short axis, whichever way you're going, short or long. You have to have that in the view to state something. Because most of the time, you know, we are seeing regular pathologies, and for the first few, most of the time, 90%, 80% of the time tells you what are you going to see in short axis, but you'll be surprised, you know, sometimes you'll be surprised that you see something entirely different which you were not expecting. So make sure that when you find this one, you focus on that, and when you transition from short to long, you stay focused on this dark area and get the split. I think that's about it. That's the last case. So here you can say that there's an anechoic area in the posterior tibialis tendon mid-substance, suggestive of intra-substance partial split tear. Or actually, don't say split tear, because there's no really split. It's just right in the middle. You would say intra-substance partial tear, and how you would say it.